Hey everyone, our project is titled Evaluation of an Intervention to Increase Advanced Directives and Documentation at Loyola MacNeal FMC. The project was led by 3 residents at MacNeal Hospital. I'm Vivian Harvey.
I'm Marinara Conception.
And I'm Rebecca Utterman.
We had the help of our attendings, Dr. Jordan, Dr. Merrill, and Dr. Hutchinson as well. An important service family medicine physicians can provide is understanding and respecting a patient's wishes, often in the form of advanced directives. However, in our residency program and beyond, having these discussions, documenting the patient's wishes, and acting on these requests has persistently been a difficult task. As you can see in QR code 1, several challenges prevent providers at our clinic from having these discussions. We have found the provider often has limited education on advanced directives, especially residents. Providers are often unsure of when to have the discussion. The patient sometimes doesn't understand the value of the discussion. There's often inadequate time during a visit. Finally, there is no standardized way of documenting advanced care planning discussions in our current EMR.
Our project is designed to decrease these challenges. Studies have trialed methods to increase the completion of advanced directives, including mailing forms to the patient's homes and providing education post-hospitalization. All of these methods have had different outcomes. More consistently, patients have found to prefer that their primary care doctor lead these discussions. On the next slide, we want to introduce you to some definitions used in our project. FMC refers to the MacNeal Family Medicine Center. ACP refers to advanced care planning. The 2 advanced direct care planning documents we focused on were the POA and PULSE. The POA refers to power of attorney, which is the person you select to make your healthcare decisions if you aren't able to speak for yourself. The criteria used to determine if someone qualified for a POA discussion was if the patient was 18 years or older and have capacity at the time of signing. A PULSE is a physician order of life-sustaining treatment, where the patient decides which life-sustaining treatment they would want. The criteria used to determine if the patient qualified for a PULSE discussion was if the provider answered yes to the surprise question. If you wouldn't be surprised if the patient passed away within the next year. On this slide, you can see examples of the Illinois POA and PULSE form.
Our Family Medicine Center has a house call program, and we targeted these 60 patients for our project. To be a homebound patient, you must meet certain criteria that makes you homebound indefinitely or temporarily. These patients are often unable to leave the home due to the need for supportive devices, special transportation, or help from another person. As a result, many of these patients have shorter predicted lifespans due to their age, comorbidities, and immobility, and can benefit from advanced directive discussions. Overall, our study aimed to determine whether our developed system was successful in increasing the number of discussions and documentation within this at-risk population. As you can see on slide 4 and 5 of our QR code 1, we created a toolkit to guide residents through their visit. Our goal was to standardize documentation and billing of advanced directives in Epic by showing residents how to create an ACP note as well as bill correctly. We discussed with an advanced directive expert at Loyola, our parent hospital, the best way to standardize the uploading and labeling of the ACP documents to Epic. Finally, we activated Epic's display of advanced directives in the banner so all providers can easily check to see if their patient has an ACP document on file, as you can see in the red circle.
Looking at preliminary data in QR code number 2, at the beginning of our project, only 16% of residents believed that they had had adequate education on advanced directives. 72% of residents were only somewhat confident or not confident in advanced care discussions. The majority of senior residents had never completed a power of attorney, 90%, or PULSed, 80%, in the outpatient setting, and 88% of seniors had only had 0 to 2 advanced care planning discussions in the last year, not very many. Reviewing our baseline data, looking at QR code number 3, we started our project with 54 house call patients, 11% already had a power of attorney in the EMR, and 9% of those who qualified already had a post in the EMR. And out of the 54 patients, only 13% have been asked about advanced care planning in the year prior to the start of our project. At the beginning of our project, we decided to set some end goals. Our goal was to have 50% of qualifying patients with a POA in the EMR, 50% of qualifying patients with a post in the EMR, and 70% of qualifying patients were to have an advanced care planning discussion documented in the EMR by the end of our project. As described in our methods, we developed our intervention over 6 3-week cycles while tracking the number of discussions and completed post and POA forms. We monitored secondary outcomes, including billing, ACP note documentation, and on-file status of these documents within the Epic EMR system.
In QR Code 4, you can review the extensive work that was completed within 3 cycles using the QR code on our original poster. Within each cycle, we reviewed the data and discussed what was or wasn't working. We then made modifications to our system and training to work to improve results. You can review this in detail at your leisure. For example, in cycle 1, the residents had 6 discussions, but often forgot to create an ACP note or bill correctly, so we added reminders. In cycle 2, we found forms were not being scanned correctly to Epic to appear as, quote, on file, so we added a special scanning folder for a more streamlined process. After cycle 3, we added a series of pre-stamped envelopes to the kit so patients could more easily return the forms. Finally, in the last 3 cycles, we tried to encourage the house call attendants to take a more central role in training to make it a more sustainable process for the future. In QR Code 5, post-survey data was collected from our residents. Of the residents that responded to the survey, 67% of the patients, 67% of our residents participated in the project. A guest lecture was given to improve education on advanced directives. 50% of the residents attended, and the majority of them found it moderately to extremely helpful. We found greater than 89% of our residents had an understanding of advanced directives, PULSE, and POA. 57% of the residents felt very confident or moderately confident in advanced care discussions, which is much improved from the pre-survey. 82% and 68% have still never completed a POA or PULSE respectively in the outpatient setting. However, this is still an improvement from the pre-survey data. 86% of residents have had at least 1 or more advanced care planning discussions within the last year.
In QR Code 6, aggregate data collected over the 5-month period of our project showed 71.6% of our patients had at least 1 discussion by the end of our data collection, which was over 5 times as many patients as at the project start. We also saw an increase in the number of POAs obtained. Now 26.7% of the patients who qualify have a POA in Epic, and 21.4% of the patients who qualify have a PULSE in Epic. This was an increase of a factor of 2.4 and 2.3 respectively. Not all of these forms ended up on file due to errors with scanning, but are still accessible in the EMR, which counts. Of note, patients who were added or deceased during the time period may have slight impacts on data. Back to the poster, our conclusions show that our intervention led to a substantial increase in advanced directives, as well as better education for residents on this topic. Overall, we were able to develop a standardized system for documenting, billing, and uploading ACP documents.
We found that ACP discussions are complicated, involving legal and ethical questions such as evaluating capacity and navigating the EMR, which can easily lead to confusion from the provider. We found that often multiple discussions are needed to finally result in a POA or PULSE document signed, and providers' strategies and motivation varies widely when encountering an undecided patient. Our data was limited to 1 specific group, so future models could be applied to other populations in our clinic, such as hospital follow-ups or Medicare wellness visits. But ultimately, the sustainability depends on attendings and residents taking an interest in this complex matter. Thank you.